Alright, welcome back to NBME 22. So today I'm just going to wrap this up. There isn't really much left to do. We're already in block 4. We're on the last 40 questions of block 4. So as usual, keep in mind the main concept here is to understand the way you're supposed to tackle the questions, figure out what's happening, and then keep in mind what are things that are common on NBME, especially if you're trying to prepare specifically for the NBME. And always make sure you Google things if you don't know much about it. Search in your first aid and try to find other relevant questions. And let's just get through this. So this question actually was a little weird. Definitely caught a lot of people off guard. It got me off guard too. So this one says a 72-year-old man with multiple myeloma agrees to participate in an investigational chemotherapy clinical trial. Prior to enrollment in the study, peripheral blood B and T lymphocytes are isolated and undergo southern blot analysis of lymphoid cell-specific genes. Using a single B lymphocyte J region probe, analysis of the B lymphocyte DNA shows a 1.5 kilobyte band. Analysis of the T lymphocyte DNA using the same J region probe shows a 6 kilobyte band. The 6 kilobyte band most likely signifies which of the following, right? And then you have the constant region, V to J, V to D, V to V to D, V to J, D to J, these weird gene rearrangements, or an unrearranged immunoglobulin gene. Now, questions, when you're reading them, right, if everything doesn't make sense to you while you're reading the question, it ends up being very intimidating. You're just going to be like, what did I just read? And then get a little scared, get a little worried, anxiety kicks in, and things just go downhill from there. The main idea is to make sure that you absorb as much as possible. So you obviously get there's something here happening about VDJ recombination. You saw it in immunology a little bit, and you definitely know what southern blot is from the snowdrop mnemonic. Right, so southern blot is for DNA. All right, so far that's about all we can get, and they made it pretty clear because they even mentioned DNA themselves. Now there's a size difference. There's a 1.5 kilobyte band and a 6 kilobyte band, and we know we're talking a little bit about multiple myeloma, but that's really all we had to work off of. Nothing enough. Now, looking at the answer choices, my thinking was, these three, I really can't tell the difference between, right? Whether you did a D to J, V to D, or V to J, doesn't mean, anything in terms of sizes of bands. Like, those rearrangements are just going to occur, and you're not really doing something specific enough to catch what type of rearrangement occurred, right? This probe doesn't look like it's exactly good enough to do such a job, right? And I was very confident it most likely was not C at all because we're using a J region probe, right? We're using a J probe, so our answer should have something to do with J, but really these three answer choices don't make any sense. So I did knock them out. And then we were between a constant region gene rearrangement or an unrearranged immunoglobulin gene. I chose A as my answer. Right, and here the correct answer was E. So I thought this might be like the constant region, which might be why it's bigger. It's the one that doesn't change, etc., etc. So let's take a look at what they're actually talking about, right? So if we go back to immunology, let's see. So they're talking about like the Ig light chain structure. Where would they talk about that? Lymphoid structure. Oh, right here. Okay, perfect. All right, so this is the thing we're looking at. We have our remember the FC component is the one that's constant, right? And you have your hypervariable stuff. You can see your VDJ stuff everywhere. The pink area has V, D, and J. Okay, this image, the way it's drawn out, a lot of people tend to confuse it. They really take it exactly as given. So they're like, okay, the left one has V, the right one has D and J. No, it's both of them. They both have V, D, J. The green areas have V and J only in the light chain. There's no D in the light chain. Okay, so that's stuff you definitely need to know. Now, based off of this, you were supposed to figure out what they're trying to do, and it really wasn't that easy. It really wasn't that easy. I mean, they've spelled it out for you, the random recombination of VJ light chains or VDJ heavy chains, and this is the heavy chain, the bigger one, right? But there's really nothing for you to get from this page that'll help you answer that question. So the concept is a convoluted way of asking if you know how VDJ recombination works. which is that it is actually an example of altering the DNA of the B or T lymphocyte, right? This is how we can make antibodies of all types to attack all kinds of antigens. Southern blot technique, so when they use a probe against some region and outputting a size of 1.5 kilobytes or 6 kilobytes, this is telling you the size of the DNA fragment in each cell. It doesn't matter if they say J probe or a constant region probe, they're just saying they're targeting some nucleotide sequence found in the Ig locus, TCR beta chain locus, respectively to B or T cells, whichever one they're doing. The confusing part could be wondering how you would know whether you're partly through rearrangements, which are choices B, C, or D, or if it hasn't occurred at all, which is the correct answer as choice E. Here the concept is that B cells undergo VDJ rearrangement in the bone marrow, while T cells do it in the thymus, and it all happens at once. So a plasma cell in the blood, like in multiple myeloma, would have already fully undergone recombination, while a T cell in the blood could either be fully educated and have finished VDJ recombination or immature, hasn't started VDJ. Since the T cell gene was 6 kilobytes and definitely bigger than the 1.5 kilobyte gene, the T cell has not undergone recombination yet. And how you would know that is beyond me, but now that you've done this question, you might have a better idea at this. But the point is, it was definitely one of those questions that you can go ahead and forfeit, get it wrong. Every NBME has at least 4 to 5 questions that you're like 100% bound to get it wrong unless you're lucky, and lucky being either you by luck pick the right answer choice or by luck have somehow at some point heard of the topic being discussed. Another thing is that NBME has been picking on really absurd questions that are somehow related to multiple myeloma. As you can see here, this thing was related to multiple myeloma, but it could be related to anything else as well. Another NBME had a very weird question about multiple myeloma regarding the monoclonality of cells. And remember, monoclonal cells are cancerous, but it was really weird. They were talking about some kind of weird IG related stuff in that question too, and it's like those questions are really not something that you're truly expected to know for step 1, so don't worry too much about it. A 38-year-old man with Down syndrome is brought to the physician by his nephew for a follow-up exam. He had lived with his parents until their death 2 years ago, but he now lives with his sister and her children. He receives Social Security insurance benefits from his deceased father's account, and this is currently the family's only income. He has missed his last 4 scheduled visits. He is unkempt and malodorous, which is definitely a big problem. Right, so someone's not taking care of him, and he appears anxious and hyper-vigilant. He startles when his nephew speaks, and he shrinks away when the physician reaches to pat his shoulder, which, in case you don't know, is a big sign of physical abuse, right? So, first of all, the patient, the 38-year-old man, has Down syndrome, so he's more like a kid than he is an adult, mentally. Startling when someone speaks is a sign of you fearing that person's voice, and if I'm reaching out for you when you get scared, or you kind of like hide yourself or defend yourself, that kind of shows that someone's been reaching out to hit you. The patient used to be pleasant and relaxed. He has had a 14-pound weight loss since his last appointment 3 months ago. When the physician asks to interview the patient alone, the nephew refuses to leave the room, which is a huge no-no, right? You never say no to the physician. What is this nephew doing? Definitely hiding something. Which of the following is the most appropriate initial action by the physician? Call the cops, man. And then you look at the answer choices, and the closest thing to that is just let adult APS, right? Contact Adult Protective Services. Ethics. It is beyond evident that the 38-year-old man with Down syndrome is being abused at home. He startled upon hearing the nephew speak, and he guarded when the physician reached out for him. The nephew not wanting to leave the patient alone and disregarding an honest adult right is a huge giveaway that the nephew is scared. Contact APS and do not let the Down syndrome patient go home with the nephew. Chances are they treat him like shit at home and they're just keeping him there because of the Social Security benefits. Right? This question gave you everything. The motive, the presentation, all of that was there. 53-year-old woman shows evidence of adrenal failure. On CT scan, both adrenal glands appear normal in configuration but decreased in size. Which of the following is the most likely diagnosis? Okay, so this was a very interesting question because this is something very NBME style, right? 2 sentences and then you have to give an answer. and they picked on something that you really might not feel very comfortable about. When you read the question, you finish it, you really don't know what might have caused it, right? What could cause adrenal failure and make both adrenal glands appear, normal in configuration but decreased in size? So pretty much atrophy, right? And then you look at all your answer choices. So autoimmune adrenalitis was actually the correct answer, so we'll come back to that. Let's look at the others first. Disseminated coccidioidomycosis. This one really doesn't have much to do with the adrenal gland, right? Coccidioid, we're not really going to be seeing this issue causing adrenal gland to bilaterally be atrophied, so we're going to leave that alone. Metastatic carcinoma from the lung. Metastasis is also something that usually occurs unilaterally. Retroperitoneal idiopathic fibrosis. I mean, like retroperitoneal stuff, again, doesn't really necessarily have to be bilateral, and if it is, it could actually cause what's being seen in this patient, but it would only cause the decrease in size, maybe because you fibrose the blood vessel. It wouldn't cause adrenal failure necessarily. All right, and then tuberculosis, that's related to Potts syndrome and all the disseminated tuberculosis and all of that. That would cause adrenal failure, but it wouldn't really necessarily cause them to decrease in size. Right? This is a very interesting question. A lot of people must have gotten this wrong because a lot of these answer choices are very tricky. I can see people picking D, I can see people picking E, but here it was just A. It caused both things. It's autoimmune, which is why it's bilateral, and it's causing adrenal failure, right? And it's just an autoimmune inflammation of the adrenal gland. Basically, you're killing your own adrenal gland. That's all it really was. It's a very, low yield kind of thing. It doesn't really seem to occur a lot. It definitely doesn't pop up in questions a lot. I don't think I've ever really seen a question like this before. But, this question kind of tests your ability to be able to knock out other answer choices and logically come down to what's most likely the correct answer. Okay, so it was just A for this patient. Here, some level of genetics. So 45-year-old woman comes to the physician for follow-up exam 8 weeks after beginning tamoxifen therapy for estrogen and progesterone positive invasive ductal carcinoma of the breast. Her 50-year-old sister also has hormone-sensitive breast cancer treated with tamoxifen. Physical exam shows no abnormalities. Serum studies show decreased concentrations of endoxifen, the active metabolite of the prodrug tamoxifen. Genetic analysis shows the homozygous presence of cytochrome P450, 2d64 alleles. Okay, so homozygous presence is being seen in genetic analysis of who? I guess the 45-year-old woman. Which of the following best represents the likelihood that this patient's sister has the same alleles, right? And this also was a question that I was very, taken aback by when I read it, because I was like, what are they talking about here? How am I supposed to pick a percentage here? This isn't really necessarily about percentages in the same manner that most questions are, but, I figured if they're asking it, obviously it must be doable. I was confident that the answer would not be, 0%, because clearly some kind of genetic thing is happening if they're both having breast cancer. So I definitely, I went ahead and I told myself that it's most likely not A. And then I reread the question, which really sucks. It sucks if you have to reread the question. It wastes a lot of time. But I had to reread the question a little more deeply, because I was like, there must have been something I missed, and there really wasn't. The only thing I didn't pay attention to very accurately the first time I read it was the homozygous part. Okay, so genetic analysis shows homozygous presence of cytochrome P450, which is an enzyme. Right. So when you're thinking genetics and you're thinking, when you're thinking genetics, you want to think of all the things that occur from the genetics chapter. And remember, anything related to enzymes, cytochrome P450 was usually autosomal recessive, and they gave you the homozygous thing, which you really want to pay attention to. Right. So homozygous presence of an autosomal recessive thing would give you disease. Autosomal dominant disorders usually present as defects in structural genes. Autosomal recessive disorders usually present as enzyme deficiencies, which would be relevant here. P450 is an enzyme, so we are probably dealing with an autosomal recessive disorder. Furthermore, the question states there was a homozygous presence of P450. In autosomal recessive problems, parents are usually heterozygous, meaning that 1/4 of their kids will be affected. Of course, half the kids will be carriers, and 1/4 of their kids will be unaffected. Okay, so based off of this breakdown, it was pretty safe to go ahead and pick 25%, and you'd be done. All right, so That's really all the question was asking about the patient's sister having the same alleles. And the patient's sister had a 1/4 chance because um, what was a 50-year-old sister has tamoxifen treatment. Yeah. And see, the only thing was that serum studies showed decreased concentrations of endoxifen, right? And that decreased concentration of endoxifen, which is a metabolite, means that you're not breaking it down, so you don't have the enzyme. Right? That's kind of what they're trying to get at in a sense. Very interesting question. Kind of fucked up because it'll confuse people. It'll intimidate people. It might feel like there's too much going on at the same time, but you have to be able to organize your thinking and figure out what's happening. Also, keep in mind with autosomal recessives, there's always one more thing you want to remember about autosomal recessive that's also very critical, and that's the concept of 2/3, right? Unaffected individuals with affected siblings has 2/3 probability of being a carrier, right? And this 2/3 plays a role very frequently. Autosomal recessive genetics is a pretty big topic NBME likes to pick on. Right, so and by big topic, I mean that it's been popping up in a lot of NBMEs back to back. Right. Now this question, we didn't even need the picture, and I actually didn't write a single thing here because this was very much, again, the conditional probability type of thing. 22-year-old, and we talked about conditional probability in the video right before this, which was just a little discussion about how to tackle questions based off of what is most likely. A 22-year-old man comes to the physician because of infertility. The photomicrograph shows tissue obtained on biopsy of the scrotal testes. Which of the following is the most likely genetic abnormality? And I'll be honest, I have no idea what the fuck I'm seeing here. Right? I really can't tell anything here, and the main reason this is even here is probably just to, again, intimidate you and confuse you. But if a 22-year-old man comes to a physician because of infertility, the first thing you want to think of is what is the most likely thing someone comes to the clinic for infertility purposes, right? And if we go to reproductive, they tell you reproductive path, right? This one right here, Klinefelter, male, 47XXY, testicular atrophy, right? Common cause of hypogonadism seen in infertility workup. Very common cause, right? 47XXY. And that was E, right? That's the answer right here. Very straightforward. Right, so don't overthink, don't confuse yourself. Just go with, what's most likely. You don't even need the photomicrograph here. This one, 42-year-old man is brought to the emergency department because he says he feels as if he's frozen in ice. Examination shows muscle rigidity. Toxicology screen shows evidence of exposure to MPTP, which you might remember from your neurology section under Parkinson's disease. Which of the following neuronal cell bodies are primarily affected? Well, if you remember the MPTP relation with Parkinson's disease, then you're going to pick the answer choice that's related to Parkinson. Parkinson is related to dopamine, so you're really between B and C. And dopamine is more so related to substantia nigra, specifically substantia nigra pars compacta, right? SNPC. So that was just it. MPTP is a prodrug to the neurotoxin MPP+, which causes permanent symptoms of Parkinson's disease by destroying dopaminergic neurons in the substantia nigra of the brain. Right, and they discuss this in the book too. So let's take a look at it. 564. Right, neurodegenerative disorders. When you talk about Parkinson's disease, after looking at all the typical stuff about it, MPTP is also discussed. Right, a contaminant in many illegal drugs is metabolized to MPP+, which is toxic to the substantia nigra. Right. So another scare to kind of throw you off from doing drugs, but God knows how common that contaminant is. And then this section is something you really need to spend a little time and memorize as well. I did make a color-coded thing with like my own, understanding of each hormone to kind of make sense out of, what the up and down arrows here would be. So you can kind of, practically memorize the up and down arrows here. The color coding is red is lack, green is excess, right? And then for each hormone, I kind of came up with what they're supposed to do. So if you have, for example, depression, right? Right here, if you have depression, so I put that dopamine is one for reward, right? And then norepinephrine is the one for activity, and serotonin is the one for pretty much happiness. You're not going to have any of them, right? Everything's going to be low. And it's easy to remember depression because everything is low in depression. But things where things are up and down, like Huntington, right? You have to remember that in Huntington, dopamine is high because dopamine is only low necessarily, or between the two, dopamine is low in Parkinson, right? These two guys are the ones where remembering the up and downs is a little harder, right? A little harder. So you spend a little bit of time on this and you pretty much easily just memorize it. But the other cool thing about this page is the location. If you remember these locations, right? Norepinephrine coming from the locus coeruleus, serotonin from the raphe nucleus, GABA from nucleus accumbens, and acetylcholine from main nert, then you can actually knock out a couple of these answer choices because they're here, right? They put everything in these answer choices. And of course, knowing where something comes from is important because you see they have two answer choices for each thing, right? So if serotonin was the correct answer choice, you would have to remember, does serotonin come from the raphe nucleus or does it come from locus coeruleus? And right here you will see serotonin comes from raphe nucleus. So you do need to know the anatomy of where those hormones are synthesized as well. This one, 3-day-old full-term male newborn is brought to the physician by his mother because of a 24-hour history of yellow skin, which is extremely common and most likely completely benign, right? Then they tell you he appears healthy. So full-term, appears healthy, everything's fine. Physical exam shows mild jaundice. Lab studies show a hemoglobin concentration of 17 grams per deciliter and a total serum bilirubin concentration of 10. With an indirect component of 8. So a lot of it is just indirect. The jaundice resolves 5 days later because it was very benign, so now we know exactly what the problem was. A deficiency of which of the following is most likely cause of the jaundice in this patient. A lot of it is indirect. It wasn't getting conjugated, most likely because this newborn didn't have enough of the conjugation enzyme, right? So that would just be E. A lack of hepatic UDP glucuronosyltransferase activity. Newborns have immature glucuronosyltransferase activity, and this is very common in newborns. A little bit of phototherapy can help make the bilirubin more soluble, and they'll be all right. This 26-year-old nulligravid woman comes to the physician because she has been unable to conceive for the past year. She also has had pain during sexual intercourse. Menses occur at irregular 2 to 3 month intervals. Last menstrual period was 8 months ago. Physical exam shows no abnormalities. Serum studies show decreased concentrations of estrogen, FSH, and LH. Dysfunction of which of the following is the most likely cause of her infertility and dyspareunia? So everything seems fine, but she hasn't menstruated in 8 months. She can't get pregnant because her hormones are all, not exactly at the right balance. She's never been pregnant. Okay, so can't really tell why any of this is happening to her. But then you look at the answer choices. Dysfunction of which of the following? So adrenal gland, hypothalamus, ovarian FSH, ovarian LH receptors, vaginal estrogen receptors. All right, it definitely doesn't look like the problem is a receptor. The problem is that the patient isn't even making it, right? Decreased concentrations of estrogen, FSH, and LH. And FSH and LH, when you see that there's decreased concentrations of FSH and LH, that rings a bell for the hypothalamus. Not even just the adrenal gland. The adrenal gland would just be estrogen, if anything, right? But if you're not making FSH or LH, most likely this patient has some kind of issue with her hypothalamus. She's not making it, and that was really all the answer was. But I'm not entirely sure what's wrong with the patient. Like, why this would happen to someone, I'm not really sure. Right, but yeah, that was, this question is really just testing you on where things come from, and FSH and LH come from the hypothalamus. So that's really all you could do for that question here. This was a really easy question. So 86-year-old man who lives in a skilled nursing care facility is brought to the physician because of a 3-week history of chronic non-productive cough. He says he's tired in the mornings because the cough interrupts his sleep. Physical exam shows no abnormalities except for the cough. A chest x-ray shows no abnormalities. In addition to further evaluation to determine the cause of his cough, which of the following drugs is most appropriate to treat the patient while avoiding adverse effects of constipation? An adverse effect of constipation usually, or most importantly, really only comes from opioids, right? So we're going to avoid opioids, which means we're definitely not going to give codeine. We're not going to give morphine, right? Theotropium, remember theotropium, there was a mnemonic. The mnemonic is, I pray that Theo gets well or can breathe soon, I guess. Can breathe soon. And that mnemonic is supposed to, the I pray part is supposed to remind you of ipratropium. Theo in Spanish means uncle, but theotropium is also the other medication here. And then basically the concept here is that those medications are for asthma, right? So I pray that Theo can breathe soon. Those are not going to be what's going to help this patient. We haven't been given anything for this patient to really necessarily have asthma, where there's no reason for us to think so. Now diphenhydramine, right? This is completely irrelevant because if we look at it, there's two things I want to talk about: that medication, and then I want to talk about the Beers criteria of things. So let me see. Oh, respiratory form. Sorry. Yeah. Right. So diphenhydramine is an H1 histamine blocker, right? And this is used for allergy, motion sickness, and sleep aid, which really, again, would not help this patient. But remember your Beers criteria, right? Beers criteria is something that often, can be tested. It'll definitely be on your step one, because this is what they use to kind of help you, pick an answer correctly, but more so they use it to confuse you. Step one writers use it to confuse you, because you might get a question where everything seems fine and all the medication seems just right, and then you have to pick something, right? So Beers criteria, widely used criteria to develop to reduce potentially inappropriate prescribing and harmful polypharmacy in the geriatric population, right? If you're going into geriatrics, if that's what you're going to be practicing, you really need to know there's a lot of medications you don't want to give to elderly people, right? Especially medications of this caliber right here, right? Anticholinergics, antidepressants, antihistamines, and opioids, because each of these can cause. Anticholinergics can increase risk of delirium. Antidepressants also can risk delirium. Antihistamines can cause sedation, which could actually lead to falling, right? And you don't want to increase the risk of falling. And then opioids will cause constipation, all of which are things that you don't want to put an older person through. And then of course benzodiazepines, NSAIDs, PPIs, like omeprazole. Right, older people you don't give a lot of these medications to. So just based off of that, it was also enough to figure out you wouldn't give them diphenhydramine, right? Just remember that. Even if they didn't tell you that, this question didn't even need to have this. It could have just said, what is the best medication to give? That's it. And you would not choose codeine, morphine, right? Because those are opioids. You would not choose diphenhydramine because, well, one thing is not relevant to coughing, but second of all, because he's old. Theotropium also you would not choose just because it's not relevant to coughing, but it's okay on the Beers criteria. And dextromethorphan is the number one medication everyone in America takes if they're coughing. I've been taking it forever because I've been coughing forever. And, now my shit is getting a lot better. Dextromethorphan often comes with other things mixed into the syrup, and those other things can sedate the patient a little bit, right? The trade name in America are the medications Dayquil and NyQuil. And usually you would go with Dayquil for elderly patients because it doesn't have much sedative quality to it. Alright, so Mr. Ragra here is saying that this is definitely one of those questions that they love repeating. And, I can see it happening. I could totally see it happening because pharm, right? Most people that are taking NBME are still pretty early in their step 1 prep, and pharm type questions can often mess up students who are still new to step 1 prep. So you don't want to miss questions like that one. All right. Now from here on, I haven't yet finished writing out the explanations for the rest of them, but let's see. Hold on, where are we right now? We're on page 170. Okay, so I could stop here. There's only 30 questions left now, right? So I can answer these and keep going, but I'd like having the explanation on the screen too. So there's only 30 questions left. I'm going to finish this up right now while I drink my coffee, and then I'll be back again to finish up the final 30 questions and wrap up NBME 22. Thank you very much for joining, and I'll see you guys again very soon.